Hello everybody, my name is Manuela Stoicescu. I am consultant internal medicine physician, PhD, assistant professor of University of Oradea, Faculty of Medicine and Pharmacy, Medical Disciplines Department, Romania. Before I start my presentation, I want to thank you very much committee organizing for the invitation, especially Miss Nivelita Samara, because she invited me at this conference and give me this opportunity to present my original case report. I'm so sorry that I can't be with you together in reality of this conference, but at the same time, I'm very glad that I have this opportunity to present in video presentation my original case report with topic the real intraoperative diagnosis of a patient with lipopenia and arterial hypotension. Before I start the presentation, I want to say that the main objective of this case presentation was for me to determine the real cause of a 50-year-old patient that presented into emergency service for an episode of lipopenia and arterial hypotension. The value of blood pressure was 16/14 mm mercury. I am presenting the clinical case of a 50-year-old patient that come at the emergency service for an episode of lipopenia and arterial hypotension. The blood pressure was very low, 16/14 mm mercury. I am mentioning that during the anamnesis, no source of bleeding has been not revealed, such as hematemesis, melena, or menometrorrhagia, thus the patient being in menopause. During the medical objective examination, the following are observed: pale skin, tachycardia, the rate heart was 105 beats per minute, normal vesicular sound, and the value of blood pressure was very low, 16/14 mm mercury. In this slide, I put this photo for you because I want to see very good together the face of the patient, and in this slide we see very good that the pale of the skin was relieved. In the next slide, I put the ECG of the patient because I want to see everybody very good that the rate heart was 105 beats per minute. So in this ECG we constate that exists sinusoid tachycardia. In the next slide, follow the aspect of the patient with in time when I check the blood pressure, and I put this slide for you to try to attract attention that in moment when I check the blood pressure of the patient, the value of blood pressure was very low, 16/14 mm mercury. After that, follow palpating the abdomen. At palpating the abdomen was insensitive, soft, elastic, and participating at the respiratory movements. I insist very much about this aspect at the objectival examination of the abdomen because the negative Lundberg sign I discovered without clinical signs of peritoneal irritation and without tenderness. In the next slide, follow the image when I make palpation of the abdomen, and I put there this image for you because I want to relieve that after I make palpation of the abdomen, this was insensitive, soft, very elastic, so without tenderness, without sign of peritoneal irritation. Rectal touch was made to exclude upper gastrointestinal bleeding, melena, and also peritoneal irritation, but rectal touch relieve normal aspect of stools without pain during the maneuver. In the next slide, follow the image with the aspect of the stool after rectal touch, and we see very good together that the color of the stool was brown, so was normal, and I excluded melena. Laboratory examinations. Of course, in this moment was very important what the paraclinical examinations have shown, and I saw that the rate of sedimentation of erythrocyte was a little increased, 24 per 14 millimeter. The level of fibrinogen also was increased, 518 milligram per deciliter. The level of hemoglobin was 11 gram per deciliter. The level of hematocrit was 42%, and the level of erythrocytes, white blood cell, and platelets was in normal range, and also otherwise everything within normal limits. In this moment, the diagnosis was lipopenia and arterial hypotension of unknown etiology. In this stage, with a diagnosis of lipopenia and arterial hypotension of unknown etiology, and in order to sustain the blood pressure, a treatment with injectomate with dopamine, 5 dopamine ampoules in 500 ml saline solution with a rate of administration 0.2 ml per hour intravenous was initiated. After this therapy intravenous continue with dopamine, the patient's evolution was with maintaining the blood pressure level at the same value for approximately 20 minutes, so for a very short time period. But unexpected, after that, the blood pressure gets to a lower value of blood pressure, respectively 15 per 13 millimeter mercury. So the conclusion was that the value of blood pressure become low in time of continued perfusion with dopamine. In this moment, an emergency abdominal ultrasound was performed, which relieves an increased quantity of intra-abdominal fluid, which does not allow the visualization of the internal organs. In the next slide, follow the image of the abdominal ultrasound echo, and in this image we see very good that exists a very increased quantity of fluid in the intra-abdominal cavity, and this fluid covers all internal organs and don't permit the visualization of internal organs. In the next slide, follow another image of the patient at the abdominal ultrasound, and also in this image we see again together very good that exists very increased quantity of fluid in the intra-abdominal cavity, and this fluid covers all internal organs and don't permit the visualization of internal organs. Of course, this fluid in the intra-abdominal cavity was unexpected discovered after unexpected image and surprising image discovered after we make abdominal echo. In this moment, of course, a question was raised whether this could be a cytic fluid, but this was totally discordance with the patient's clinical aspect, because I insist she did not present any clinical sign of liver cirrhosis or heart failure, or for example nephrotic syndrome, did not have edema of the legs or fluid collections in other serous, reason for which a paracentesis was performed emergently in this moment. In the next slide, follow the paracentesis. So after I make the paracentesis, surprisingly that the extracted liquid consists in a fresh blood. So the conclusion was that the patient had hemoperitoneum. In this slide, I put in this image for you to try to relieve the paracentesis and the very unexpected and surprising result for us. In time when we make paracentesis, I discovered that the result was fresh blood, so the conclusion was the fluid in the intra-abdominal cavity visualized at the abdominal echo was fresh blood, was hemoperitoneum. Of course, in the very instance, the main problem was now what could be the hemoperitoneum etiology, since the patient not had no history of trauma in the past. Of course, in this moment, I make a re-evaluation of diagnosis, and the diagnosis now was hemoperitoneum, lipopenia, arterial hypotension, and tendency at hemorrhagic shock. In that moment, the patient was transferred in the general surgery department for emergency laparotomy. And after the surgery, it is indicated that the real diagnosis of the patient was reversed. So, after emergency laparotomy, broken and bleeding right ovarian tumor with hemoperitoneum was discovered. So a hemoperitoneal suction drainage was performed and a right ovarian resection with a favorable outcome after surgery and the saving of the patient's life. So, finally, the real diagnosis of the patient, I insist about this idea, was discovered only after surgery, after emergency laparotomy. So the final intraoperative diagnosis of the patient was right ovarian tumor broken and hemorrhagic bleeding with hemoperitoneum, fatness, hypotension, and a tendency for hemorrhagic shock. In this slide, I put for you the post-operatory piece, and we see very good there in this image the aspect of the right ovarian tumor broken and bleeding. Results and discussions. The onset of this clinical case was surprisingly fraught with a vital risk complication, the apparition of the hemoperitoneum, which clinically developed through lipopenia and hypotension. I insist that the blood pressure was very, very low in the first moment, 16/14 millimeter mercury. Also that the patient's clinical aspect could be suggested an active bleeding due to the pale skin, sinus tachycardia, faintness, hypotension, and decreased blood pressure under dopamine therapy. Its source could not be detected from the first instance. Conclusions. The sudden onset of the clinical aspect with a vital risk complication, hemoperitoneum, and a hemorrhagic shock tendency. The second important conclusion is that the hemoperitoneum is the single situation of acute surgical abdomen in which the clinical sign of peritoneal irritation do not appear. Another very important conclusion is that any intra-abdominal fluid that is found by performing ultrasound should be immediately punctured in order to pre-exclude the existence of a vital risk hemoperitoneum for not be mistake-interpreted, such as simple flight of ascites. The lack of an important anemic syndrome, because the symptoms were at onset, the presence of the inflammatory syndrome could have suggested the presence of a tumor. Clinical signs of active bleeding were present: pallor, tachycardia, hypotension, fatness, but the bleeding source could not be detected from the very beginning. And the finally conclusion, and maybe the most important conclusion, was that the hemoperitoneum is one of the most dangerous emergency in the medical practice, that we don't put the correct diagnosis at the time, it is possible to lose the patient's life. Every intra-abdominal fluid discovered after abdominal echo, I insist very, very much about this idea, need to be punctured immediately to exclude hemoperitoneum for not be confused such a simple flight of ascites and to save the patient's life. So this was my original case report, and since I recognize that this case also surprised me in moment when I diagnosticate this patient, and this was the reason that I select this case to present for you. And this is a flower for you, for everybody, and thank you very much for your attention.